cholesteatoma, I really do everything I can to preserve the native anatomy, as much native anatomy as possible, right? So we want to try to preserve that, obviously, for many reasons, right? Because obviously there's better healing time, right? Patients don't have to heal as much, like as you'll see here coming up with a wall down cavity, that takes a lot more time to heal that. And as a result, there's easier long-term care for, an intact canal wall tip mastoid, right? If they're going to be wearing hearing aids, it's much easier to fit those, right? Because they don't have a big meatoplasty, which we'll talk about. Or even sometimes with large meatoplasties, those may not work, and they might require a bone-anchored hearing aid, for example, which, that could be either that's surgical. Sometimes there's non-surgical bone-anchored hearing aids that could be used. Necessarily after they've healed, you don't have to observe water precautions, right? When you have, we'll talk a little bit more about that with the wall down, but sometimes water precautions are necessary for wall down folks. The disadvantages is it's a lot more technically difficult, right? You're leaving the intact canal wall. You have to work around that bony canal, try to get any residual skin from under the canal as it goes through the antrum into the epitympanum. So then as a result of that, you can leave disease, right? So you can have the recurrence or the recidivism rate is a lot higher due to the fact that it's more challenging to eradicate that. So we use the term extirpate, right? We're trying to remove disease from the mastoid and the middle ear. And when you're working around these bony apertures like this or partitions, it's challenging sometimes to get all that out. And I'm not sure, Peter, you probably haven't seen it yet, but Louisa, if you guys are doing, I think Tashni may use endoscopes occasionally in the ear. Has that been?
Only, Tashni usually only has a look with an endoscope, but right. She usually prefers the microscope, whereas Mantis is more sort of comfortable doing things endoscopically. But not that commonly for cholesteatoma unless it's very limited from what I've seen.
Yeah. So in this day and age, a lot more folks are doing endoscopic ear surgery. Personally, I don't use it as a primary modality. I will use it adjunctively. So in a case like this, I'll look underneath. I'll take a 0-degree scope or a 30-degree scope, and sometimes I can look from the mastoid side through the antrum into the epitympanum. And use some instruments there to see, have I left some skin behind, et cetera, or sometimes in the sinus tympani, right? So as you're looking down in the middle ear side, transcanal middle ear side, you can look underneath the sinus tympani. Sometimes that can be a challenge there too. So as a result of these, sometimes you can be staged, a staged procedure, which we talk a little bit about in a little while. I stage a lot of these. What do we mean by staged? Well, many times in intact canal wall tip mastoids, we're removing disease, but oftentimes the cholesteatoma has eroded some of the acicular chain, right? And so I remove those ear bones occasionally if they're involved. And many times we hope that there's a stapes at least behind. And then I'll reconstruct the drum over the stapes with some cartilage. And in the hopes of going back about 9 months later to do a second look surgery to see if they recurred the disease and then reconstruct the ear bone chain with a prosthetic. Many people will do everything at the first pass. I think sometimes that's hard when you're reconstructing an eardrum and then trying to rebuild ear bones at the same time, because that's a lot of things that have to heal just right for that to work. And so there can be challenges where if the cartilage graft doesn't heal right, you've got a prosthetic, it might come through the repair. There could be a lot of nuance to that. So I try to minimize all the variables. I want it to heal well. And then ultimately we do want to have a second look to make sure they haven't recurred the disease, because as we just said, if you do an intact canal wall procedure, there's a high likelihood you will have, it's a higher likelihood that you could have recurrent disease. And as a result, it's harder to detect. So sometimes when you rebuild the drums and you put cartilage in there, you can't see through the drum like you could before, for example. So you have to be very vigilant about folks that might be under the impression that because they've had one surgery, the ear is clear and there's no other issues. And then they might show up years later with a draining ear and a really bad problem, So it's really important to be clear that this could be a recurrent problem, that they need to make sure they have adequate follow-up. Okay. Now the contraindications, I've listed some here. And Peter, I'm going to ask you a couple of questions is, when we talk about taking a canal wall down, right? Sometimes people will say if it's the only hearing ear with a cholesteatoma, many people will say, well, you should take that down because you don't want them to go undocumented or followed, and then all of a sudden they have a canal fistula, and then they lose the only hearing ear. So some people say you should exteriorize. Obviously, if you already have a labyrinthine fistula, that means you've already eroded into the labyrinth, right? And you probably have skin there that you'll have to leave over it in the form of a matrix so that you don't lose the hearing or the balance. But by having skin in there, you have to exteriorize that by its nature. Some will say if there's a long-standing disease in the ear or they have bad eustachian tube dysfunction, you might have to do that. But Peter, can you think of some other circumstances where you might have to take someone's canal wall down going into surgery? Are there any other things that you think about?
I think whichever modality we use will be dictated by the extent of the disease. So if there's cholesteatoma and it's extending maybe from the middle ear attic into the mastoid antrum, for instance, then you don't have a choice. You need to follow it and take down some part of the posterior wall. I don't know whether that answers it to some extent.
Well, you mean if you have disease from the middle ear going into the antrum, you have to take the wall down?
Yes, because then you might have the canal wall up, but I think you are better off following the disease backwards, and so you are likely to take the canal wall down, but to leave it intact in that instance might not be the very best of situations. I don't know.
Okay, so if you have disease that's going through the middle ear into the antrum, that's pretty common. That can happen a lot. So I don't think you always have to take the canal down. That's what we're talking about here is if you have disease in this graphic here, if it's coming through where it says fossa incudus near that incus bridge, if you don't have a fistula in the horizontal dome or something like this, you could try to keep the wall up. What I'm getting at is, are there any other situations where you definitely would have to take the wall down? Louisa, can you think of some possible, other than the ones I've listed here, are there any other situations where you might be thinking, oh, I'm probably gonna have to take the wall down?
Definitely if you have cholesteatoma sitting on the lateral circular canal, you definitely want to take that down for disease monitoring. The thing about leaving the canal up is you need good follow-up for your patients. I mean, you're going to follow up both patients, but you would consider, definitely consider taking the canal wall down if you think this is going to be a patient that's not going to be able to come back reliably if there's a problem. So that's sort of the big things that we think about when we consider canal wall up versus canal wall down. I'm trying to think.
That's absolutely. So sometimes social situations, right? If you have a bad disease in the ear and you're worried the patient may not follow back up, you may think about that. What about anatomically? Is there anything else anatomically that you think, wow, I can't really get into I can't clean this out safely. I'm gonna have to exteriorize it. What we mean by exteriorize it is now open everything up so that the skin is not trapped and that you can clean it in the clinic, or it just exteriorizes. Any other anatomic features of the temporal bone that might sort of force your hand into doing that?
If you've got a very low hanging segment,
yes,
then you'll struggle quite a bit. You'll struggle quite a bit. So that could definitely be a consideration. That's something you might think about.
Absolutely, absolutely. That's absolutely right. So if you can't get into the antrum and to clean that disease, you might have this low flying tegmen that's bowed down. And so as a result, you may have to exteriorize that and take the wall down. Exactly. What other anatomic features might you have that's either native anatomy or disease? What else could be there that would say, well, we got to take the canal down?
A high-riding anteriorly placed sigmoid sinus.
Yes, exactly right. You nailed it. Absolutely. So that sigmoid there in that drawing right here, right? That's pretty favorable here. But what you've seen these, you may have seen these. Sometimes that sigmoid sinus is so far, it's almost by the perifacial air cell tracts, right? It's almost by the descending segment of the facial nerve. And when you get to that sort of level, boy, there's really no place there. And you might have disease tracking underneath there. Don't have any room to aerate the mastoid or even clean it out. So that's exactly another indication why. You got it. So two things. You got brain coming down, you got sigmoid sinus coming forward. Both of those really constrict the mastoid itself and may force your hand into taking down the wall. What about, we mentioned disease. Peter, you mentioned some disease. I'm not sure who else is in the room. Who's there? You got Lisa, Peter, and Hey, how are you? Sorry, I can't. It's a small picture that I can't quite make out the faces there. So sorry. Any other thoughts? What do you think about? Is there any other situations that you think about that might say, well, we really have to exteriorize this disease? Where else do we think? Okay, so we talk about cholesteatoma traditionally being located in the middle ear, right? And in the mastoid. Where else can cholesteatomas form?
The canal.
Yeah, right, the ear canal, right? If you get skin trapped under skin and it erodes, what can that do?
It can reach the posterior wall.
Yeah, you could erode right through the ear canal, right? So if you've got a big ear canal fistula, and now you've got, the ear canal is in contact or connection with the mastoid, sometimes you can repair that. Sometimes you can fix that with a little maybe Simba cartilage from the ear, maybe a little conchal cartilage, but oftentimes not. And so in that situation, your hand is kind of forced there too. You got to take the wall down. Another situation, I'm not sure how much ear surgery you've seen, but the issue is that, when we close the ear, you have to be careful when you do intact canal wall surgery. So the other cause is iatrogenic, right? So you see in this diagram, you see the bony ear canal wall, right? So this is a really important thing. You see how tall the bony ear canal is?
Yeah.
Sometimes when people are doing surgeries, they can foreshorten that. They're drilling on the canal, thinning it, but they might accidentally shorten the canal. So that could create a problem when you close the soft tissue envelopes down, right? So when you lift you're all familiar with the vascular strip, right? When you lift the vascular strip up off the canal wall, right, and you lay that back down, if that canal height is too short, what happens to the vascular strip?
It's buried.
It gets buried, or it actually works its way back behind the bony ear canal. Now you've got canal skin working its way behind your bony canal. So you can have these little fistula tracts that can go unbeknownst to you. Because why? In the clinic, if you're not looking back there, sometimes the way the ear is and the meatus, when you put the ear back down, the meatus is pretty thick there. And if you don't really toggle back with your speculum and your line of view, you might miss the fact that that skin now is actually subluxed behind the bony ear canal. And so what can happen is skin can be migrating back into the mastoid. And what can happen is that can go undetected for a long time until the patient shows up in the clinic going, man, my ear is just draining and draining and draining. And you don't see any other findings. You're looking around until you see this big heap of macerated squamous debris on the back side of the canal. So you have to be careful when you're doing, ear surgery, because you can make those little nuances, those little changes to the anatomies and the features can actually lead to iatrogenic problems, right? Not just, putting holes in the tegmen, dural exposures, putting holes in the ear canal. You can actually do things like that and shorten it. Okay. And then when you have that problem, that sometimes is hard to fix that problem. And so then you may have to take them and actually take the whole canal down. Now you're thinking, oh, geez, now I got to go in. I got to take the whole canal wall down. I have to now exteriorize that whole problem because now I can't reconstitute that natural partition between the mastoid and the ear canal. Does that make sense?
Yeah.
So that's something to really think about. That's really something to think about. So good. So let's talk about another case. Okay, so now you got a 67-year-old's got again, this is kind of a classic presentation for concerns, right? So somebody who comes in with a long-standing history of chronic otorrhea, we always think about that as, that's cholesteatoma until proven otherwise, right? So what unfortunately happens here is a lot of, they see their primary care doc, they just keep putting drops at it and it clears it up and then it comes right back. So sometimes these folks don't get otologic care for a long time because they just keep treating the intermittent infection. But you should always be thinking chronic otorrhea is a cholesteatoma until proven otherwise. So it's been treated with drops, fields of hearing obviously is gradually declined. There's no vertigo, okay? Has some clicking, tinnitus in the ear, some funny sounds, which is not uncommon when you have fluid in the ear. So Peter, you're on the phone with Louisa late at night and she's like, hey, tell me about that ear. So can you, without reading some of those things, can you describe to her what you're seeing?
Okay. So I see the ear canal is hyperemic. This seems to be a right ear.
Why do you think it's a right ear?
I'm wondering whether. Oh, okay. Well,
No, I just want to know. Just tell me what's making you. Tell me what your orientation is. So what makes you think it's a right ear?
I was wondering whether initially I was wondering whether this was the handle of malice, but it's not. This must be. Is it the handle of malice?
Yeah.
Okay. Okay, then the light reflects on the left means that we are looking at the left ear with what looks like a perforation in the inferior aspect with some retraction. And then
retraction, where's it at? Where's the retraction?
I think it's perforated.
Okay.
There's a perforation. And on the anterior aspect, I see some anterior superior aspect. I see some what looks like crusting. I'm not very certain what it is.
Is that on the anterior aspect or is that the posterior aspect?
The left ear. Probably I need to work it out a bit.
Okay, let's think it through. Think about it.
Yes, please. I'm thinking about it. The left.
Yeah. So it's not. It's not.
It's on the posterior superior aspect. Sorry.
Okay.
So that brownish lesion there. This one.
The you called it a crust, right? Which is an accurate description, right? It's a crust.
Yes.
Yeah.
Okay.
Which is usually kind of made of what? What's oftentimes a crust made out of?
Like a dried discharge, or it could. That's what I think about to start with.
Yeah, skin, wax, dried drainage. Exactly. Yeah. Okay. Anything else you see there?
Well, beside the perforation what I call the light reflex. I don't know whether it's still is. It doesn't look like the light reflex in normal situations. That's about.
Yeah, why is it not a normal light reflex there? Is there, what do you think? Does the
The
drum,
light reflex.
look, I was gonna say, does the drum look normal there in the anterior, superior, and anterior inferior quadrant there?
No, it doesn't look normal. That white patch doesn't. It's not like the rays you see with the light reflex. So I don't know whether it's some sclerosis or something like that. Not very certain.
Okay, all right. You guys have anything else? Louisa, what else do you see anything else? Any other descriptions here that you see?
Yeah, sure. So it's a left ear. I can see that there's a crux in the posterior superior quadrant, which might be suspicious for cholesteatoma. You'd have to clean that up and see if it's keratin. That past tensor, it looks like a retraction perforation to me. So there is a perforation inferior posteriorly, but the entire past tensor of the drum to me looks like it's retracted, and it looks like it's kind of retracted onto the handle of the malleus. There's an area of hyperemia right above what I think is the capitulum stapes potentially, and the canal also looks quite sort of red and angry and inflamed. I'm not sure. I mean, you usually shouldn't see the stapes that clearly, so I think that this drum is probably very retracted, and I would be suspicious for incurostapedal erosion. And then, I mean, the sputum seems to have that skin just looks like it's creeping beneath the neck of the malleus. You can't really delineate that, so there's definitely some either retraction pocket or nothing. I mean, you'd have to clean it off to see, but it's quite suspicious for cholesteatoma. Yeah, that's what I would have.
Yeah, exactly. And so exactly right, guys. So this, obviously, when you look at the canal, obviously you see that dry debris on the superior aspects of the canal above the sputum. It obviously means it's been draining. It's hyperemic. It's, inflamed. Obviously, it's probably been recently treated. Big crust there. Yeah, I agree. I can't see any of the IS joint at all. That little nub and low, it seems a bit low to be stapes. It could just be a little polyp. Could be a little hyperemia from that, a little, mucosal inflammation. And then you look at it, that whole, into what's left of the intact part of the drum on the, anterior superior and anterior inferior, that's pretty tympanosclerotic, right? And then it does look like it looks like a perforation on the posterior inferior quadrant. It's kind of what we call a marginal perforation, right? It goes all the way up to the annulus of the drum, which then is pretty hyperemic along the posterior border, right along there. Yeah. So Peter, what's next for this patient? Do you just give him some drops and say, call me if it drains again, or what do you think? What's your next step after you just saw the patient in the clinic?
Well, so I'll clean it well, the ear well, see whether I can get off what looks like the crust and see what is beneath it. And then I'll have an audiogram done, or tuning forks to start with, test to start with, and then have an audiogram done. But I think this ear eventually will need some examination and anesthesia to be certain of we do an exploratory tympanotomy to see what is behind all that we are seeing. We could do some imaging prior to surgery though, and then get a better picture of what is happening in the middle ear, and then possibly proceed to do an exploratory tympanotomy.
Okay. All right. So you mentioned an audiogram. Now we did the tuning fork then. So we mentioned if the tuning fork lateralizes to the left and bone is greater than air conduction, can you kind of guess what you might be thinking, what you might be seeing on the audiogram before you see the audiogram? What would that suggest to you with it's lateralizing to the left with bone conduction greater than air conduction?
Then we are likely to have a left conductive hearing loss.
Okay. So here's your audiogram. Can you read that for us?
Okay. So for the right ear, we have a mild sensorineural hearing loss, which no, not a mild. So we will start from a mild, rising to normal, and then sloping down to a moderate mixed hearing loss on the right. And then for the left side, the left side will also be a mild mixed hearing loss, which also rises the mild to severe mixed hearing loss on the left. Yes.
So what do your colleagues think? What do you guys think about that audio interpretation? Any thoughts?
So to me, it looks like in the right ear. Well, let's look at the pathology ears first. So it's an audiogram, it's got mass bone conduction, and it looks like there's, I think there's predominantly a conductive hearing loss in the left ear. Looks like it's sort of moderate. Well, it is mixed. It's a mixed hearing loss in the higher frequencies, but the dominant feature is that there's an air-going gap. That air-going gap, if I just had to eyeball it, probably looking at about 35 dB, I'd say. Maybe a bit less. I'd have to calculate it over 3 frequencies. But I think it's more like a moderate to moderate. Actually, I mean, the sensorineural component ends up being profound in that left ear. Sorry, it ends up being moderate. So I'd say it's a mixed hearing loss in the left ear, predominantly conductive. So moderate to profound downslope.
Right. So I would agree. So so it's at 40. So that's really at a moderate. So I'd say moderate rising to mild, sloping to a profound mixed hearing loss.
Yeah.
Right. And then Peter, on the right side, that's really pretty much a sensorineural loss. There's that one bone line. I'd probably repeat that. I don't think that that's a conductive loss there. I think it could be. You'd have to maybe retest that there, but I think that would be predominantly a sensorineural loss.
Yes.
Yeah. But definitely. So the good news, so this is reassuring. So right off the bat, you know that inner ear is intact, right, on the left side. And so despite a really, bad looking ear, diseased ear, we know that before doing anything else, that the inner ear has not been violated by the disease, right? I mean, you can only see what you can see in the clinic, but at least gives you a little bit of reassurance that going into the next steps or stages of the care for the patient, that there's at least the inner ear is intact, right? So, all right, Peter, so what was next? So you said, so now you got an audio, you've got a physical exam, you've got a high suspicion, obviously, for cholesteatoma. You removed a crust in the clinic. You probably saw that the incudostapedial joint is eroded. You've got perforation in the back of the drum. You got really bad retraction pocket up high. And you got an audiogram that shows sort of what you expect to see. Obviously, there's obviously a large mechanical loss superimposed on an inner ear loss, which for somebody in their 60s, late 60s, you'd expect them to have some inner ear, maybe presbyacusis, right? Some high frequency inner ear loss. So that's not likely related to the disease. So what's your next step?
We'll go on to do some CT scan of the temporal bones imaging. Yes.
Okay, so you get a CT. All right. So can you walk us through what you're looking at?
Okay. So the scan. So this is a CT scan of the temporal bone on the left ear. The top scan is the coronal view. It shows a soft tissue density in the middle ear. The scutum is blunted. There's some erosion of ossicles, the malleus and the incus will both be affected. And that's about, well, it seems that the soft tissue density surrounds all the ossicles, so it's encasing the ossicles.
Mm-hmm. So you mentioned middle ear. Can you be more specific about the parts of the middle ear that the disease seems to be involved in?
Yes, please. The tympanic cavity, and a bit of it in the external canal as well. Because you see the tympanic membrane, and then anterior to the tympanic membrane is some soft tissue density as well. Or lateral to the tympanic membrane is some soft tissue density as well.
Okay. So the middle ear, do we divide it up into any kind of compartments at all?
Okay. Yes, Prof, I get what you mean. So it involves both the epitympanum as well as the mesotympanum. The Prusak space also has some soft tissue density in the coronal view.
Okay. Is there how would you define on that coronal view? So remember, we have an epitympanum, a mesotympanum, and a hypotympanum, right?
Yes, Prof.
Is there any way to differentiate those compartments on that scan that you see on the coronal above?
If we draw a horizontal line on the superior end of the external canal, that should, and then also on the inferior aspect of the inferior border of the external canal, that should define the mesotympanum, and the epitympanum will be superior to it.
Mm-hmm. So based on that delineation that you just mentioned, can you tell me where you presume the disease to be involving? Is it, you just mentioned, epitympanum and mesotympanum, but based on how you delineated the mesotympanum with extended lines, does it involve more than those two compartments?
Yes, Prof, I still think it involves the epitympanum as well as the mesotympanum.
And the hypotympanum, right?
Yeah.
Okay.
Do you see the disease going below a line if you extended a line straight across? It seems now it's in the high.
I don't know. Well, for the hypotympanum, I need to be shown that one. I don't know whether we see the disease in the hypotympanum now.
Louisa,
on the coronal.
what do you guys think?
I think there is hypotympanic involvement based on sorry, I just stepped out for a moment, but in essence, your mesotympanum is everything that you can see. If you were looking under a microscope from externally, that would be your mesotympanum, and inferior to that would be hypotympanum, and superior to that would be epitympanum. And I think if you look down that canal, I do think there's hypotympanic involvement.
Mm-hmm. Yeah, absolutely. So Peter, does that make sense? So if you were to draw a line on the coronal straight down the barrel of the canal along the superior canal into the middle ear, right?
Yes.
Anything above that line is in the epitympanic space. Anything below a line at the bottom of the canal drawn extended toward into that, and you'd run right into the cochlea. Anything below that line is the hypotympanic space, right?
Yes.
So you've got a soft tissue density, which you suspect based on your clinical exam. And now remember, we talked about the beginning of this several weeks ago, and you guys already know, you can't diagnose cholesteatoma off of a CT, right? Now with an MRI, diffusion weighted imaging, you can, but for the CT scan without a clinical exam, it could be anything. That could be, bubble gum, that could be wax, that could be who knows, right? But in this clinical context, when you look in the ear, you think, okay, that's probably cholesteatoma. Could it be scar? Could it be adhesions? Sure, but not likely. Especially the ear is fairly dry, not actively infected like it looked like it was not. So, you suspect here that the cholesteatoma is really kind of filling all three spaces of the middle ear. And you're right, you've got, looks like some vesicular erosion, the scutum is blunted or has been eroded. Yeah, so so that, so that's pretty good. Now, the other issues to look at, any other things you want to comment on this? When you're looking at a scan, is there anything else you're thinking about? You want to look at, as you're thinking about maybe surgery, what else are you looking at here?
Yeah, so you're definitely going to have a look and see if there's any evidence of previous surgery, which is
Mhm.
only limited view. So, but from what I see, there, it doesn't look like the patients had previous surgery. You want to look at the utilization pattern of the actual mastoid air cells, whether they are well pneumatized and well aerated. Specifically looking for sclerotic mastoid. You would want to make sure that all your critical structures are covered in bones, so there should not be semicircular canal dehiscence, facial nerve dehiscence, and tegmen breach. That tegmen looks quite straight. To me, it doesn't look particularly downward sloping, it's just a consideration if you're going to be drilling. Just to read at what level you can expect to encounter the tegmen so that you don't breach it. Yeah, I think those are the main things I would these particular view.
Absolutely, that's good. So you want to be looking at the other adjacent structures and see what else is involved, right? The tegmen looks like it's intact. It doesn't look like there's any intracranial extension, right? Oda capsule looks like it's intact. Floor of the skull. I'm not seeing any erosion toward that. What's that big, Peter, that big gray thing right below the cochlea? What would that thing be? Is that cholesteatoma?
No, Prof. The internal acoustic meatus.
Is that the internal acoustic meatus? Louisa, do you guys agree with that?
No.
We're still on the coronal. We're still on the coronal view. We haven't gone to the horizontal yet. I'm talking about the coronal view up above, Peter. So right below the cochlea, on the upper, on the coronal, that big gray mass below the cochlea, is that the internal acoustic meat?
No. From the internal carotid artery.
That's the carotid artery. Yeah, exactly. Right. Yeah. So it hasn't fistulized in that. Looks like there's bone over it. So that's good. That's a good thing, right? So these are all things that you want to be thinking about because you're probably going to be in that ear at some point surgically. And you're thinking, okay, what else is going on? What else do I need to be aware of here? Okay, good. Okay, so Peter, walk us through the bottom scan. What are you seeing there?
The axial view, you mean? The bottom scan, yes, please. So that's the axial view of the temporal bone. So there's soft tissue density around the ossicles with ossicular erosion. You don't see the ossicles in their entirety, and the cochlea is, we see the cochlea, we see the internal acoustic meatus. We see a well pneumatized, a well aerated mastoid. And well, so I'll suspect this is the cut at the level of, because we can see the cochlea and see the mastoid air cells. Maybe we'll say this is a cut at the level of the mesotympanic.
Right, so you want to say always at the level of, right? So you're kind of at the level of the cochlea. Now, do you see, tell me about the ossicles. Can you describe the condition of the ossicles a little more detail?
Okay, so this is where we should be seeing the ice cone, ice cream cone, and the ice cream shape of the head of a malleus and the neck of the incus, and that kind of picture is not present. We you don't see the ossicles, the two ossicles being in continuity at that point. So I think there's some erosion of the ossicles.
Louisa, do you have anything else? Do you guys have anything else to add?
So just looking at the axial, there is no ear pacification, as Peter said. I do think that there's some vesicular erosion. I can't see the state pieces in its entirety, but you might need to have one view to scroll. So I do think that there is some vesicular erosion, especially on that incus. Then, other than that, it's only a single view, but I don't know if I would add much more in this one image.
Right. Yeah. But you guys are right. I mean, you're seeing a little bit of the IS joint there. Maybe superstructure of the stapes there is we're not quite at the level of the oval window foot plate there. Hard to tell. But definitely some erosion there. Exactly right. And it's a well-pneumatized, well-aerated mastoid. And usually, Peter, we would call that the internal auditory canal, right? You're at the level of the IC, right? You can see a bit of the porus acousticus. So, Peter, if you go where the porus acousticus is and you go along the posterior aspect of the facial or the temporal bone, right? Now you're along the posterior fossa dura. I see a couple of things there. I see almost like a little sharp hook and a little inlet there. And as you go laterally, there's almost like a little depression. What are those two things?
Probably, I can't locate where you mean so well.
Do you know where the internal auditory?
Okay. So, Prof, this and this. I don't know whether
I can't see what you're pointing. I can't see what you're pointing to. Sorry, I'm trying to describe. So you see the cochlea, you see the cochlear canal, and then the internal auditory canal. It goes toward the porus acousticus, right?
Yes.
Now go lateral along the posterior aspect of the temporal bone. And there's a little hook there on the back of the posterior aspect, and then there's like a little inlet there. What is that?
The cochlear aqueduct.
Okay, Louisa, do you agree with that, or do you guys agree with that?
I mean, I think that you're talking about the sigmoid sinus was the one depression. I think
yes, laterally, you're absolutely right. So yeah, the big depression laterally is the sigmoid, right? But then more medially, what is that?
It might be vestibular aqueduct.
The which one?
The vestibular aqueduct.
Yeah, exactly right. You got it. Vestibular aqueduct. Probably not the cochlear aqueduct. Where does the vestibular aqueduct run? Where do you guys, Peter, where does that run to? So if you're in the temporal bone, how do you know that? So Louise is saying that's the vestibular aqueduct. Why do you think that? Or why do you think she's saying that? And if you're not sure, ask her why she's saying that.
Prof, I want to ask you.
No.
So Louisa, why are you saying that, Louisa?
So because of the orientation of where it is, so the vestibular aqueduct is going to come up sort of in the same plane as you expect your posterior semicircular canal to start coming up, and that's quite useful when you can measure the sizes if you're looking for an enlarged vestibular aqueduct. So that would be my answer.
Yeah, remember the vestibular aqueduct. Remember there's the the actual the organ itself. Remember, it's a dural reflection on the back of the dura there. Do you remember Donaldson's line, Peter, when you're doing a mastoidectomy? So let's go back. Let's go right here.
What's Donaldson's line?
Okay. So you guys see this picture. You haven't heard of Donaldson's line?
No, I have to.
Oh, okay. So so look at do you see the horizontal semicircular canal dome?
Yes.
So if you draw a line parallel to the horizontal semicircular canal dome, and you draw it straight back into the presigmoid dura, That's where the endolymphatic sac lives. That's how you find the endolymphatic sac. Okay. So they call that Donaldson's line. So if you draw this line straight back, because you think about where does the endolymphatic sac, right? We worry about that with, sometimes people open that up for Meniere's disease and drain it. More importantly, it's where, you know, you can get endolymphatic sac tumors, right? They're usually more spontaneous mutation, but they can happen with von Hippel-Lindau, right? So vestibular, you know, if you draw a line straight back, bisecting the horizontal dome, meaning parallel to it though, but splitting in half, straight back to the presigmoid dura, that's when you find the endolymphatic sac. Now, the endolymphatic sac, so that's on the posterior fossa dura, presigmoid posterior fossa dura. And the endolymphatic duct runs out of that thing called the operculum, and it goes right toward the common crus, right? So when you're drilling out a labyrinthectomy, if you guys have drilled out a labyrinthectomy in the lab, when you start drilling out that, you know where the common crus is? The common crus is where the non-ampulated end of the posterior canal meets the non-ampulated end of the superior canal. When you drill through that, you'll see a fibrous sort of a band. That's the endolymphatic duct that's now running right toward the common crus. So when you look at it radiographically, it's that. You're seeing it as it exits the operculum of the endolymphatic sac, it's becoming the duct. Now, when that's widened, that can lead to hearing loss. So children may have sudden loss, postlingual hearing loss. It may happen after a head trauma or whatnot. And you get a CT scan, they may have a widened or a dilated or an enlarged vestibular aqueduct, right? That makes sense. Is that kind of ringing a bell?
Yes, bro.
Yeah. So it's always really good to look at all these scans. I know we're getting a little off topic on this, but I still think but when I'm looking at a temporal bone, I'm looking at all these features. Let's see, there's one other thing I'm gonna ask you about on that axial view. Do you see the cochlea?
Yeah.
Yes, bro.
Okay. There's almost like a black stripe or a dark gray stripe that's running right in front of the cochlea, kind of anterior lateral to it. What do you suppose that is?
A cochlear aqueduct.
You're gonna get no, it's not. We'll talk about you want to ask a colleague.
I've answered enough questions. Whoever can answer it.
This one.
Yeah, this last
That's
thing.
right.
Do you know what I'm talking
Oh,
about?
no, it looks like a fracture.
Yeah, I'm gonna say it's a
Yeah.
fracture.
It's not a fracture, but what would be running right there? It's probably not a fracture, but it's probably something else. What's in that area up there?
Endolymphatic duct.
No.
I'll give you a hint, Peter. It's not a duct. It's
It's
not a duct. It's not a duct of any type. So your answer should not have duct in it.
Okay.
I'll give you a hint. It's a neural structure. What lives up there? What's the biggest neural structure in the temporal bone we worry about? What do we never want to damage?
Facial nerve.
Facial nerve.
Yeah.
What's the biggest part of
No.
Yeah, what comes off the geniculate ganglion? There you go. You're getting close.
Greatest
Yeah, GSPN. That's probably part of the GSPN. You're catching a bottom part of it. Aha. It's not the cochlear aqueduct. So Peter, since we're on that topic, sorry, I know we won't get to our last case today. Sorry, but this is good stuff. I hope this is helpful for you. Let's go back to this real quick. Right there. So if I had to ask you guys where on this, if you're drilling, okay, you're drilling this mastoid and you go, where would the cochlear aqueduct be? We just talked about where the endolymphatic sac and the endolymphatic duct would be, Donaldson's line. And then the duct goes toward the common crus. Where would the cochlear aqueduct be on this scan? So if I said to you, Peter, okay, you're sitting in the bone lab and this is what it looks like. You're sitting there in front of a temporal bone. You've opened it up to this point. I'm going to say, okay, Peter, I'm going to come back in about 10 minutes, 15 minutes. And I want you to show me the cochlear aqueduct. Where would you drill? Where would you start looking for that? And you can phone a friend if you need to.
Well, Prof, I haven't gotten to that yet, so I don't know. I suppose we'll be looking for it around where the cochlea is, but please, I don't have an answer.
Okay.
I need help.
What do you think, guys? Can you help out your colleague?
Where would I start?
Yeah, where can you show me? Well, show me where it roughly would be, and then we think about more detail about where are the anatomic structures that you'd hone in on that would then really kind of, you know, isolate where it'd be located.
I'm not too sure where I would start looking for a Prof.
Okay. So,
I mean,
all right.
it would be inferior to the lateral semicircular canal.
Okay, it's inferior to that one for sure. So, okay,
Yeah.
but be more specific.
Inferior and superior.
Inferior and superior to what?
Inferior and so inferior to the lateral semicircular canal.
But
Just
how inferior though?
Close to the sinusoidal angle.
So that's going posterior. That's you might be thinking about the inferior petrosal sinus. That's different. Okay. So the cochlear aqueduct, guys, this is how children that get meningitis when they're babies, how they get cochlear ossificans. Okay, so where's it located? So it's basically a conduit from the subarachnoid space into the cochlea. It is going to dump into the near the round window niche, right into near the round window. So where would the round window be if you're on this side of the ear? Whereabouts is the round window? Can you guesstimate where that would be located in the cochlea? You can't see it because the canal's up.
Yeah. Yes.
Where would that be?
We'll need to do a posterior tympanotomy to be able to visualize.
Not necessarily. No, what I'm getting at is the level. Okay, so you don't see the cochlear aqueduct unless you're deep in the temporal bone. The cochlear aqueduct runs parallel to the jugular bulb and it's inferior to the posterior semicircular canal. So I wish I was there to kind of point this out a little bit better, but you see the horizontal canal?
Yes,
the posterior semicircular canal is going to be posterior and inferior to your horizontal canal, right?
Yeah.
You've seen that, right?
Yes.
So if you drill parallel, where's the jugular bulb going to be? The sigmoid sinus is going to go down into the mastoid tip, then it's going to curve up 90 degrees and come back down into your neck, right? So between the jugular bulb and the posterior semicircular canal, if you drill deep in that area, you're going to see a horizontal band paralleling the top of the jugular bulb that goes from the pre-sigmoid dura region right into, eventually would head toward the round window of the cochlea. Does that make sense?
Yeah.
So I want you to, I don't have a scan to show it, but what I want you to do is get online and look at like radiographic image showing cochlear aqueduct. Okay. So the cochlear aqueduct is lower than the endolymphatic duct, and it's just above, usually above your inferior limit of your dissection. You know, if you're getting down to the jugular bulb, you're below it. And if you're up to the posterior semicircular canal, you're above it. So it lives between the posterior semicircular canal and the jugular bulb, and it's deep in the bone. And when you're doing, say, a labyrinthectomy we're doing a translab surgery for a tumor, you'll cross through it, and then all of a sudden you'll get CSF, it's almost like a big CSF leak comes out of it because it contains CSF-like fluid that then drains into the cochlea. And so read up on that a little bit, but that's how children, why they become deaf when they get meningitis, is you're carrying basically microbes into the cochlea that causes an inflammatory reaction. Does that make sense?
Yeah.
That's cool.
Yeah. So good. Yeah. So two things I want you guys to look up: Donaldson's line Donaldson's line. That's a nice intraoperative way to find the lymphatic sac.
Mm.
And then the cochlear aqueduct. And then that's different than the what you talked about going to the sinodural angle. That running along there is a big vessel. That's called the inferior petrosal sinus. When you come through there, you don't want to get into that. That's a big bleeder that comes right from the sinodural angle near the sigmoid transverse junction that runs parallel along the tegmen. Yeah. Nice. Well, good guys. So I think we have, so we'll have to talk about a little bit more of the management. I have to run now, but we'll talk about the management of this one a little bit more here next time. So we'll have to wrap this up. I know these are taking a little while to get through, but we still have one more case to go after this one.
Cool.
Yes, Paul. Thank
Yeah.
Thank you.
Thanks, Rob.
Yeah. Is that helpful?
Yeah.
Yes,
very
so
good.
much.
Yeah. So key takeaways from today is really, really be descriptive with your physical exams, right? Really think them through. Look at what you're looking, describe it really in detail. And then try to extrapolate what you think that's going to look like in a CT. And don't just look at the disease on a CT. You want to look at all these structures. That's why it's really important to look at all your own films. You want to become really fundamentally sound with all the anatomy of the temporal bone. And you want to look at all these things because it could impact what you do surgically. That's separate from the direct impact of the disease itself. Does that make sense?
Yeah.
Yes,
I mean, you may have nuance of the anatomy, like Louisa said, right? Earlier we talked about, well, maybe they got a low-flying tegment. Maybe there's a far forward sigmoid sinus. Maybe there's some other feature that you're thinking, oh, wow, I may have to consent this patient for a wall down. We might have to take the wall down to clear this disease to make it safe, because there's elements of the anatomy that are really going to navigate that for us or dictate that for us. So really fundamental to really get experience with all the nuance of the temporal bone. Okay.
yes,
And,
Paul.
and then remind yourself about the GSPN, greater superficial petrosal nerve.
Mm.
Yeah. Nice. All right, guys. Have a great weekend. Good to see you as always. I'll see you guys next Friday. We'll try to finish this up. If we can't, we may have to move that one to another week because we're gonna talk about some rheumatology and otology. Okay.
Cool. Thanks, Rob.
Yes, Paul.
All right. Good to see you guys. Have a good one. Take care.
Thank you, Rob.
You bet.
Thank
Thank
you.
you guys. Take care.
Bye-bye.